The side effects were really quite manageable. There were some unusual side effects. They got some arthralgias, which means joint aches, and some rashes and fatigue. But the one intriguing thing was they also got skin cancers. They got with these squamous cell carcinomas. So these are not the same as a melanoma, but they're a type of skin cancer, which is the most common type of skin cancer we see. And so these patients getting this drug, their melanomas were melting away, but they started getting these skin cancers. So this initial study was followed up by another study with BRIM-2, which was with 100. The initial study was with about 60 patients, and then they increased it now to looking at 132 patients. Patients who had advanced melanoma, who had previous chemo and failed, but who had this particular mutation in their tumor. And they received the drug at the same dose, and lo and behold, don't have it here, but the waterfall plot was the same as those first few patients who got it. So this confirmed that this drug is very active. And these are in patients, again, who had previous treatment and still, despite previous treatment, had progressive disease. So we were looking at a response rate of somewhere around 80%, which is unheard of in melanoma. In fact, it's unheard of most malignant diseases. So then BRIM-2 was followed by BRIM-3. And in oncology, we have to demonstrate that a new treatment not only causes tumors to shrink, but it has to translate into long-term benefit to patients. And the best way to do that is to compare them with standard treatment and the new treatment and see which group does better, not just in terms of the tumor shrinkage, but do they live longer if they get this disease. So a very large international trial was launched comparing the standard DTIC to this drug in patients who have had this mutation. And this is just sort of one of the early print-offs of the results of that study. And this basically shows how the percent who are alive over time. And so the higher you up are on that line, the better you're doing. So it starts out with everyone's alive at the beginning of the study, and those who received vemurafenib, the proportion who remained alive was significantly higher than those who received the dacarbazine. Now certainly they all start to go down over time, but there was a clear advantage over the standard chemo with the vemurafenib. So much so that this study actually really hit the fan in the New York Times and other places, because people knew from the earlier studies that the vemurafenib worked so well. And if they were in this study, they ended up being on the standard arm. They weren't that happy about it. And in fact, when they did the early analysis of this study, it's not really ethical to keep putting patients on a substandard arm, or an arm that is inferior to the treatment arm. And so they had to actually stop this study and start putting people who were on the dacarbazine on the vemurafenib, because it was showing it was so much better than the standard chemo. And so this came out with another study about the same time, and the first time that any treatment for metastatic melanoma had showed that degree of improvement in an outcome over anything we'd had in the past. So that was big news for us. It seemed to benefit everybody, so we look at, is there a certain group of patients that benefit more than another with this drug? And within the study, it didn't matter how old you were, what your gender was, how sick you were, even how extensive your disease was. Everybody benefited from the vemurafenib versus the standard chemotherapy. And this is the waterfall plot of this particular trial. And you see the vemurafenib, that's one similar to what I showed you at the beginning in the phase 1 and 2 studies. Majority of people have some kind of response. There's a minority who doesn't work in at all. But again, the majority by far having tumor response, and some of them have the disease completely disappear. This is what the dacarbazine did. The majority of them progressed. They didn't respond at all. And then the proportion that did respond was significantly less than the vemurafenib. So it just did not work nearly as well as the vemurafenib. And again, some of these funny side effects started showing up in the people who are getting the vemurafenib. So you can see about 12% developed these these squamous cell carcinomas, and the keratoacanthomas and skin papillomas are kind of precursors of that. And it sounds terrible, but actually it's not a big deal. They're usually very easy to recognize on the skin, and you can take them out, you can excise them, and they're gone. They never killed anybody. They don't progress. You just have to take them off when they occur. But they're definitely present in probably 25 to 30% of patients get these skin lumps secondary to being on this drug. So monitoring is important. This is just an example of this is not all melanomas are black. This is a cutaneous melanoma, and it basically disappeared after 7 days. The next slide just shows some of these acanthomas that they can develop. It kind of looks like a squamous cell. You wouldn't be sure unless it was biopsied, but that's the kind of skin lumps that these patients get. And again, I've been using vemurafenib now for well over a year, and we see these, and we don't lose much sleep over them, but we just monitor them. So this is really, this typifies how our approach to oncology often has been. We don't really know how something works, but that doesn't stop us from using it. And really, once we use it, we get experience with it in terms of who seems to benefit from it and some of the side effects. But you always have to keep an open mind in terms of what these drugs can do. Okay, so this is just showing some of these acanthomas developing on the leg. They can also get what we call a hand-foot syndrome, where they get reddish and peely skin on the palms, and the soles of the feet can be quite uncomfortable. Again, this is a side effect. So we don't know how it's doing this, but it's causing this in some patients, and that's again the trade-off that you always have to play in trying to treat the tumor and then putting up with the toxicity of treating the tumor.